Hello again. I'm Arman Danielyan. I'm a child psychiatrist. Today we're going to be talking about international perspectives on child and adolescent mental health and what can be done both internationally but more specifically in Armenia to improve mental and emotional well-being of youth in Armenia. Um, so I guess the first question to ask is there a mental health emergency for kids and adolescents in Armenia? And so the situation with mental health in youth has been critical for Armenia for quite some time. And, you know, I'm a graduate of the medical school from Armenia myself. And I remember when we're studying psychiatry or psychology back during the Soviets. Um, I don't think we really learned much about Freud or Piaget or Erickson, and it's now kind of looking back. I of course question how could someone really become a very knowledgeable pediatric mental health specialist without knowing well and studying well these critical theories of child development. But even after the Soviets collapsed and we became more involved with Western psychiatry and started combining both our knowledge of old school and kind of newer approaches to treatment of mental health. Um, I'm not quite sure if we're still on the same level or even close to the same level as the Western pediatric psychiatry training curriculum. And um, I heard from my colleagues, and I hope this has changed, but I understand that there are not too many medical professionals or medical students who choose psychiatry as the residency training, and even less number of trainees going to child adolescent psychiatry fellowship training. And plus, of course, on top of everything, most recent war with Azerbaijan had a major impact on emotional well-being of kids and adolescents and their families, of course, as well as the whole nation in Armenia. But I'm not sure about Armenia. Again, maybe my colleagues can tell me more about the specifics of what's going on with pediatric mental health in Armenia now. But at least in the United States, there has been what's called a state of emergency in child and adolescent mental health, and at least three major professional organizations, including American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and Children's Hospital Association, agreed on the fact that something needs to be done in the field of child and adolescent mental health. And part of the reason, one of the reasons, or some of the reasons why this statement was made is because there have been soaring rates of mental health problems among children, adolescents, and their families over the course of the pandemic, most recent pandemic with COVID-19. And at least in one meta-analysis done of 29 studies, which included close to 80,000 youth globally, the pooled prevalence of both depression and anxiety almost doubled during the period of the COVID pandemic. As you can see from this slide, there have also been increasingly frequent visits to the emergency department by kids and adolescents, and of course their families. As you can see, these are the 2020 data, and these are 2018, 2019 data, and as you can see, the numbers for 2020 are significantly higher. These are number of visits, and these are the proportions, so in percentages. So there was significant increase in the emergency department visits during the COVID-19 pandemic. With more stress, of course, people also experience more depression, more anxiety, and with that comes more suicidality. And unfortunately, we also noticed increase in suicide rates. And if you look at this study published in 2021 in pediatrics, there has been a significant increase in both presence of suicide. Let me actually use the pointer here. So there has been a significant, there has been increasing number of suicide attempts, which is the black column here for 2020 compared to 2019, and there's also been increasing the percentage of suicidal ideations. But let's kind of step back for a second and talk about, how common are some of the kind of main psychiatric conditions in kids and adolescents, and what's the course of those illnesses. So from the epidemiological perspective, at least 1 out of every 3 to 4 youth is estimated to meet lifetime criteria for mental disorder. So which means that 1 in 3 to 4 kids or adolescents, at least once in their lifetime, they're going to meet criteria for psychiatric disorder based on DSM-4 or maybe ICD-10 in Europe. And children and adolescents constitute almost a third of the world population. And I didn't know this data actually, that almost 90% of those youth live in low-income and middle-income countries, and youth who live in those countries are at much higher risk of developing mental health problems. Now, depression, as you probably know, is one of the most common conditions, right, along with anxiety, of course, and some other syndromes, or nosologies. But the prevalence of major depressive disorder based on what's called National Comorbidity Survey Adolescent Supplement, which is a big study done in the United States, was 11% lifetime, which means 11% of kids experience major depressive episode at least once in their lifetime, and the 12-month prevalence is 7.5%, which means that within any 12-month period, about 7.5% of youth experience symptoms of depression meet diagnostic criteria for major depressive disorder. Most common age of onset for depression in youth is between the ages of 11 and 14, and females suffer from depression much more frequently than males. This is another representation of pretty much the same data. This is the overall prevalence of depression. As you can see, females suffer from depression much more commonly than males. This is the age representation, and this is the racial and ethnic distribution of prevalence of depression. And biracial and multiracial youth have the highest rates of depression, followed by the white Caucasians. Suicide also, as I mentioned, rose steadily between 2010 and 2020, and it peaked during the COVID pandemic. In 2018, suicide was the second leading cause of death for youth ages 10 to 24. About 18.8% of students reported having seriously considered suicide, according to CDC data. CDC is the Center for Disease Control and Prevention in the United States. And again, the females had pretty high rates, as well as white non-Hispanic students. And as you can see, there's a big number of students who identify themselves as lesbian, gay, or belong to other LGBT groups. Now, I'm not sure about the situation in Armenia, but at least in the United States, we have been seeing pretty drastic increase in what's called a non-suicidal self-injurious behaviors, which is, when kids don't necessarily want to kill themselves, but they hurt themselves. So they cut themselves, they burn themselves, and they harm themselves in any other ways. And often the parents and of course a youth ask, what does that mean when they harm themselves? Is it dangerous? And many kids believe that it's not dangerous because they don't have any intention to kill themselves, right? So, and I always tell them about this study called Treatment of Resistant Depression in Adolescents study, called TORDIA trial, which was a study which looked at adolescents who suffered from depression and who did not improve with a trial of one SSRI, and who were then randomized to a different SSRI, or a venlafaxine, which is another antidepressant, with or without cognitive behavioral therapy. And they also were assessed for presence of suicidal ideations and suicide attempts and non-suicidal self-injurious behaviors at baseline and throughout the week 24 of treatment. And as you can see here, about almost 50% of youth reported a history of self-injurious behaviors at baseline. And self-harm behavior history predicted both incidents of suicide attempts as well as incidents of non-suicidal self-injurious behaviors. And so pretty much just to kind of say in different words, what I tell my patients is that we always believe that if somebody attempted suicide, then that puts him at the highest risk of future suicide attempts. But this study actually showed that kids who harm themselves, who cut themselves, burn themselves, but they don't want to kill themselves, they still end up being at much higher risk of future suicide attempts compared to kids who in fact tried to kill themselves. So I say it is not safe. Don't really ever believe that if you're harming yourself, then you're fine, there's nothing to worry about. You are at much higher risk of future suicide attempts. It kind of sounds scary, but I think you have to tell the patients and the parents what really the data show and provide more psychoeducation. So this also refers to the same kind of information about probability of suicide during a year, or 365 days after a self-harm event. As you can see, there's a significant increase in suicidality after initial self-harm, both in young adults and adolescents. Now, I think it's really crucial to talk about trauma, because this is what really I think our nation has been going through in Armenia over the past 20, 30 years now. And we had at least 4 major events, which is the first Nagorno-Karabakh war in 1988 to 1994, then a 4-day war in 2016, then the second war in 2020, and then continuous clashes between Azerbaijan and Armenia. And it certainly can't really leave youth or adults unaffected. Now, let's look at some data about what happens when people are exposed to trauma. There are some longitudinal studies, in specific this particular study of 230 kids, including 150 kids who were exposed to repeated wartime trauma, and 84 controls, which means kids who haven't been exposed to trauma, were followed at 3 time points: at early childhood, middle childhood, and late childhood. And as you can see, those who were exposed to war trauma had significantly higher rates of PTSD, like post-traumatic stress disorder, anxiety, ADHD, depression, ODD, and other, psychiatric conditions, both in middle childhood and in late childhood, compared to controls, which are kids who were not exposed to war trauma. This is another interesting slide showing how important is it to also pay attention to the maternal well-being, because this is data showing the impact of maternal emotional distress on child psychopathology. As you can see, in those who were exposed to war, maternal emotional distress was associated with significantly higher rate of chronic pathology as well as early pathology, versus in controls, the impact wasn't there. One of the most interesting studies that I really know of, and I think it's really a beautiful study, called Bucharest Early Intervention Project, was a study done in Bucharest where they kind of looked at institutionalized kids, and the authors tried to understand what happens with these kids if they stay in the institutions versus they're taken out of the institutions and placed in foster care, where they can hopefully receive a little bit more support and more help. So in this particular study, the authors followed children from infancy through the age of 16, assessing a wide range of developmental domains like physical growth, cognitive function, social emotional development, attachment, and brain development. They also examined the effect of early institutionalization on brain and behavior development, and also examined the impact of high-quality foster care or on future development. what the authors showed, what the study showed, is that early institutional care had negative impact on measures of both visual memory and other executive functioning. And children with any history of institutional rearing had more psychiatric disorders than children without such history, which is 50 versus 20%, which is a big difference. Children removed from institutions and placed in foster families were significantly less likely to have internalizing disorders compared to those who received care as usual. Children who were placed in foster care before 24 months were more likely to have secure attachment with their caregivers. And foster care, I'm pretty sure most of you know what foster cares are, but this is the family, which is not a biological family, where the kids are placed to continue to live and function there. And it's certainly supposed to be at least better, and more caring environment than institutionalized care. This is another slide showing the data about various types of symptoms in internalizing symptoms and externalizing symptoms, as well as ADHD symptoms, and girls and boys who receive different types of care. So this is care as usual, this is disruptive foster care, this is stable foster care. As you can see, those kids who were placed in stable foster care had significantly lower rates of pretty much all of the symptoms mentioned here, and the green column shows those kids who have never been placed in institutions, so kind of normative population. As you can see here, there is, as mentioned earlier, there is a significant impact of institutionalized care on cognitive and executive functioning, and kids who were placed in foster care, which is the blue column here, showed significant improvement in like verbal, perceptual, working memory, and other cognitive and executive functioning variables. Skip this one. So childhood trauma is associated with significantly increased risk of mental health disorders like depression, anxiety, and PTSD, as well as physical problems. So kids who underwent trauma often don't take good care of themselves physically, and they end up developing obesity, diabetes, cardiovascular disease, and cancer. There's also a growing number of studies and evidence showing that trauma epigenetic mechanisms are involved deeply in trauma and transmission of trauma. And I think one of my friends and colleagues, Hacettepe Gasparian from the Yerevan State Medical University, has been working a long time on what's called transgenerational trauma and the mechanisms of how that transgenerational trauma gets transmitted from one generation to another, which I believe is also based on some biological and epigenetic mechanisms. It is really important to understand, though, again, and to emphasize that caring environment is extremely important for youth to be in, especially for youth who underwent traumatic experiences. According to some studies that I emphasized here, experience of traumatic shock among children exposed to bombing and other horrors of World War II differ for those in care of mothers or mother substitutes compared to those with absent or lost parents. This is by Freud. And many children returned home despite the dangers posed by bombing during the London Blitz. So even if they were in danger of being hurt or even killed by bombing, they still preferred to be close to their families, their mothers. And children liberated from terrorism concentration camp who were under care of Anna Freud showed significant improvement over time. Now, I'm pretty sure you know who this person is, right? This is Nietzsche, and I think one of his most famous statements was that what doesn't kill you makes you stronger, and which means that if you went through trauma or kind of any major difficulties in your life, and if you survive, then you are more, resilient. You are more capable of dealing with things, so you might even be more successful. Armenians say "kop fața չէ, ավելի կոպվեց այդ բանից, դժվարությունների մեջ avansնելուց հետո." So they say once you go through the difficulties, you are more immune to those. And this is what's called stress inoculation hypothesis, which claims that successfully navigating through life stressors may improve your ability to cope with subsequent stressors and thereby increases your psychiatric resilience. However, I don't think, and maybe unfortunately, but I don't think this notion is very true, and numerous studies suggest it otherwise. And there are some, obviously mechanisms on how you can, deal with trauma, and maybe some adaptation to trauma mechanisms, which include both genetic and psychological mechanisms. But there are some protective factors like self-control and problem-solving skills, close relationship with competent caregivers, good school and safe neighborhood. And I think, fortunately, in Armenia, especially during the war, many of people who suffered and who lost their loved ones had very strong support. But it's really important to understand that that might not be sufficient. If you have been traumatized, you need to get help. Having just supportive environment might not be sufficient. Many children who experience adverse conditions in their early years grow up to become healthy adults. That's true. And again, some predictors include behavioral and emotional self-regulation, education, mental care, relational history, emotionally responsive and competent parenting. In conclusion, I'd like to say that psychiatric disorders in children and adolescents are highly prevalent in Armenia, in the United States, and everywhere else in the world. And many studies showed that the prevalence is not that different, although there were many speculations in the past that ADHD is just a diagnosis that's mostly used in the United States but nowhere else, which is absolutely not true. Psychoeducation is very important. We need to educate our people about the importance of seeking mental health help if you go through trauma, if you have any symptoms of depression, anxiety, ADHD. It's not enough just to talk to your friends and family and teachers. It's really important, but it might not be sufficient. Please talk to professionals. If it's your child, please take him to see his or her pediatrician or a psychiatrist or a psychologist. Development of standards of care based on internationally accepted practice, guidelines and parameters is something we should really be focusing on in Armenia, because as mentioned above, I am not sure if most of our standards or guidelines in Armenia are at the level of international standards. And it's really important that we improve collaboration between professionals in Armenian diaspora, and I think many of our colleagues in diaspora have shown it throughout this past 10, 20, 30 years that they have been heavily involved in providing help to our colleagues in Armenia and even patients in Armenia and our people in Armenia. So I'd like to thank you all for listening to me, and I'm sorry that I went a little bit too fast because of the time limitations, and I'd like to again say a big thank you to my father, late Professor Arman Danielyan, who was my teacher, my first mentor, and who kind of made me believe that psychiatry is a great specialty, it's a great profession. And he always used to say, if you're a psychiatrist, you also need to study philosophy, which I unfortunately didn't do as much, but I should. But I also would like to thank many other colleagues, friends, and mentors of mine, Dr. Eleanor Kapp from the UK, late Professor Elizabeth Weller-Pogosyan from United States, Dr. Stelbello, Dr. Kovac, and many, many others. So thank you very much for your attention.